Good morning.
Good morning.
Can you hear me?
Of course.
Okay. Thank you, everybody, and I really appreciate Professor Huang and our friend Lefevre and Professor Park and any distinguished our discussant and all audience, and really appreciate the show our the very complex case. So before starting our live case demonstration, I'm gonna introduce our team. I'm D.W. Park from Assam Medical Center, and he is our senior fellow, Sang-Chul, our senior the assistant, Jang, and we will do this tough case. So, and Dr. Joe, can you present patient background?
Okay. Hello, everyone. I'm Dr. Zhou from Assam Medical Center. I want to introduce today's case. This patient is a 67 years old male patient. He admitted for the intermittent lasting chest pain. His coronary risk factor was diabetes. Actually, 1 month ago, coronary angiogram was done, and coronary angiogram showed diffuse severe stenosis at proximal to distal RCA and left main bifurcation lesions. Also, he received PCI at the proximal to distal RCA 1 month ago. Next. Okay, this is his underlying risk factors. He has diabetes, and his clinical presentation was stable angina. Next. This is echocardiac finding. His echo shows the normal systolic function and without regional wall motion abnormalities. And TMT shows the positive. And next is CAG finding. The left coronary angiogram showed the diffuse severe stenosis and proximal to distal circumflex and proximal LAD. So this is a very tough left main bifurcation lesion. And the right coronary angiogram, actually 1 month ago, we also treated with PCI. At the time, the syntax score is very high, 45 points. So at the time, we discussed with the heart team. We recommended the surgery to the patient, but he strongly refused to the surgery. So we want to decide to do the PCI.
So if I'm gonna summarize this patient is relatively young, 67-year-old male, risk factor was diabetic, and the treadmill test only positive at stage 2, ejection fraction was normal. So, and after checking of the coronary angiogram and right coronary artery diffuse disease, 1 month ago, and we treat that region with giant, 3 giant stent. So, previous slide. Okay, looking at we measure the syntax score is 45, and we're gonna show us the left coronary system. This is the area coral view, and definitely you can find severe calcification, also very acute angle of a suck. Also, the OM branch is big. Next one. This is the spiral view, and looks like very tough. And first case too much tough. So very acute angle and very tight subaosteum. And next one. This is the epicranial view, and we can easily see a very tough calcium, severe calcification before injection. That was definitely severe calcification criteria was met. So overall syntax score is 45, and the patient's diabetic, and we have heart team discussion with our cardiac surgeon, and all member is first recommend bypass surgery, second choice was PCI. We discussed the patient, and the patients strongly refused bypass surgery, so we finally decided to do PCI. So on the right coronary artery, we already treat our primary purpose this case, and we try to reduce syntax score less than 5, residual syntax score less than 5. So after seeing the first coronary angiogram, what is your choice, and any comment from discussant and the moderator?
Okay, actually you are the first, the operator of the first cases of the quite honorable. Any question or comment, particularly in the question and comment from the floor, is highly recommended. This case is a really complex cases and very exciting cases. There is a lot of the educational message from these cases.
Dr. Park. This is Dr. Jang-Whan. Hello. And I think that the
Yes.
proximal to distal lady has very severe calcium, and so I think that we definitely need the rotabulation or something. But my concern is just, very acute angular circumflex and the circumflex osteomus disease.
Yeah,
and so what is
right,
your
right.
plan on in the left main and the LAD and circumflex bifurcation area? You're gonna do the two stand strategy, the straightforwardly?
Okay, so another comment from panel discussion or?
Hello, TW, this is Thierry Lefevre. I think you have a very complex case. Of course, like you, I will recommend surgery in this case, but of course the patient refused, so you have to do it. The right was already done before. What will be the complexity is the fact that there is a lot of calcium in the left main and the proximal and mid LAD.
Definitely.
And you have also a tight lesion of the circ. So you have at least 2 or 3 bifurcations to treat.
Definitely.
So I wonder what will be your strategy in this case. I think it's very important to start with a strategy and maybe a plan B if the plan A is not working.
Definitely.
Okay, Dr. Park, this is Dr. Yoon. Maybe we can clearly see it's a quite complex disease. As Dr. Bay is pointed out, there was a long diffuse lesion with a severe calcification in the LAD. But if we do have a plan just to do an intervention, maybe just a long stenting from distal LAD to maybe left main. That's just provisional for the circumflex lesion. Maybe after that we can decide you do another is stenting for the circumflex. So first I just wanna do IBUS before proceeding the intervention.
Definitely.
About
So
Dr.
and
Yin, Dr. Yin.
so definitely under
Yeah, I'm Dr. Yin from Taiwan. To me, I think the purpose of PCI are two. First, for life saving, and second, for symptom relief. For this patient, I think cover the limit to LAD would be life saving and both symptom relief. So I will focus on this. I agree with Dr. Yin.
This is the really
so and
real candidate for the bypass surgery. So the hopefully maybe the patient refused the bypass surgery. Next option is the stenting. So when we do the stent in these cases, they look at the size of the circ and the right coronary artery. The size of the circ is maybe is a quite big branch. However, the compared to the right side is the smaller. So the fixation of the right coronary first is most important. Second one is we have to fix it the LAD. It is not easy, really complex. The technically not easy and the severe calcification. In this view, there is some angulation. So it's the region preparation modification with like the atherectomy is the highly appreciated.
Yeah, I agree
so
that.
and if you're gonna yes,
I agree that the LAD is the most important in this case, but at the same time you will not be happy to lose the circ. So at one time we will have to at least protect the circ, and of course because you will start probably with rotablation or atherectomy, you will not be able to use 2 wires during the procedure always. So I wonder what will be your strategy.
Yeah. So and some as suggested many discussions and the faculty and decision making is very difficult. But if you're gonna decide to PCI, we would like to complete revascularization. Looking at the circ region is not so small, and if remain the circ region, I think a residual syntax score more than 10. So our plan N is we try to two-stent technique to save circ and LAD. Plan B, If suck cannot save, and we just cross over. So next one. So looking at this spiral view, and one of the problem is the suck region is very acute at this point, and we usually, if you're gonna treat the complex left main stenting, we usually select a branch guiding caster. One of the most important part, if you like this severe calcification, acute suck angle, and we prefer more strong support. We choose the XB 8-inch guiding caster. That is a most important first step. And next one. And looking at the epicranial view, we can find very severe calcification from the mid-LAD, distal LAD. Next step, we should consider what we should do and treat the severe calcification region. Some operator prefer the upfront calcification, rotablation. Some operator is a salvage rotablation. The second operator, if balloon failed, then select the rotablation. And some operator initially upfront rotablation. Usually, my strategy is the next one. If looking at this is initial IBUS, and we try to pass that region is IBUS. So we can see the kinking of at the left main portion, and that means very severe calcification. IBUS cast does not pass that. Usually that phenomenon happen. I do usually direct upfront rotablation. And next one.
That is some clue for the very severe calcification.
Definitely. Okay, at the moment, and we check the IBUS, just the short segment. You can see the. Can you show us IBUS? 여기 좀 보여주세요. 돌려야지. 오케이, IBUS. 한번 돌리면서. Looking at the moment of the IBUS, some severe calcification and the encircling calcium, but the IBUS does not pass, and just we guess the very circular calcium and the lumen size of 3.0, something like that. So at this moment, we do perfect PCI. We should shift the very fast decision making. At this moment, I decide to the rotablation. And next one. And this is pullback, the rotablation, some kinking. It's not easy to pull back. It then means how much severe calcification. And next one. So I decided to upfront rotablation for that region. And the next one. So, and a previous one. So it's usually initially BMW wire, and then put the micro caster, and then the exchange to rota wire, and then next one. Here is a rota wire insertion at the tip of at the end of the LAD, and next one. So at this moment, upfront rotablation is selection size is 1.5. As there are many discussions. What is the first rotablation selection size? Some operators suggest 1.25. Some operator 1.5, 1.75. It's my choice. Usually, distal LAD region, very tight region, is 1.0 balloon does not pass that region. I select 1.25. Such like a mid-LAD region, and usually my default strategy is 1.5. So prox LAD, left main is sometimes I select 1.75, 2.0. So I think, some operator might be know, and the step of rotablation is much safe. 1.25, 1.5, 1.75 is much safe, but our government just reimbursed just one rotablation is I select 1.5. So this shows the step of rotablation, and the initially passage rotablation is like a bird beaking motion, and that is the most important part, and the slightly push and pull, and then the 20-second push and pull, and 10-second rest, and then try again. And next one. This is a 1.5 rotablation. Try to keep the 180,000 RPM, and this is the middle part, and the rotablation, and the gently, and the bird beaking motion, and the to and fro motion, and the next one. And fortunately, the past that region and the mid-distal part, and this is 1.5. We try to maintain at least 180,000 micrometer. And next one. Here is one more, next one. This is last rotabulation step is 1.5, and next one. So this is immediate after rotabulation, as shown, is lumen looks like much bigger. And then next step is we evaluated pooled arid segment using IBUS. Could you show us the IBUS image again? Okay, looking at IBUS for treatment complex PCI, as discussed yesterday, many lecture and very, very important imaging evaluation for complex PCI, and on the basis of the IBUS finding, and we make sure distal normal zone vessel size 3.0, and you can see the here, and then there is some plaque rupture, and the lumen size is 3.0. Okay, here is the encircling calcium. You can see some disruption of the calcium. 조금만 빨리 가볼까? Okay. Okay, here is some coming of diagonal branch. Diagonal branch ostium looks okay. So we don't put the protection wire diagonal branch. Okay, here, just slowly. Okay, 자 여기서 pull back. You can see some disruption of the calcium. There is some calcium particle and thrombus. That was typical image of the rotabulation work. There is, okay, this is some plaque LAD, and okay, could you show us the sarcoosteum? Okay. Sarcoosteum is looks like okay, but you know, true evaluation circle, and we should put the wire and the IBUS to suck. And could you okay, play? This is LAD osteum. Calcium was extended to the distal main and up to shaft, and after rotabulation, and you know, we can find overall calcified is disrupt well. And next one. At next stage, and we try to the suck wire, and next one, this is the Xiong blue wire, and then the okay, 이게 이건 IBUS 잘 넘어가는 거고. 그 next one, the here, and we try to the IBUS evaluation suck. Okay, so 여기가 IBUS 안 넘어가는 찍혔나? 자, next one. Okay, we try to the IBUS pass that region. 전에 거. Some, but unfortunately, IBUS does not pass the suck region because of the angle is too acute, and we cannot evaluate the suck osteum by IBUS. Okay, here is a try to the IBUS, but at the osteum of the suck IBUS does not pass. So the next one, we decide to the 2.5 compliant balloon. Okay, compliant balloon is passed well. Okay, here, test, and the next one. And we inflate the 2.5 compliant balloon, next one. And here is 2.5, expanded well, next one. This is the sarcoosteum. There is some kinking portion, and we try to several times, next one. Here, a compliant balloon, next one. And then we evaluated the suck full segment by IBUS. Could you show the suck image? suck는 우리 안 봤었나? Okay. 이게 패스하지 않았지? So, this is proceed the procedure. Any comment for up to until this moment?
So far, the way over the procedure is a very classic and educational procedure.
Yeah, I think vessel preparation was very important, and the choice of 1.5 burr was very good. Many people will use 1.25, and I think it's too small. So for this case, 1.5 was perfect. And now we have all the information. You have already protected the circ. Of course, I think that one long stent will not be enough. So even 48 will be too short. So you need at least two stents to cover the left main and the LAD. And I don't know what you will do in the circ, but maybe just protect it. I don't know. It's up to you.
Hi, Duk-Woo, it's Michael Lee. I think you've already done all the hard work. I think from here on out, it's going to be pretty straightforward. I think you're going to stent the distal to proximal LAD and then probably end up doing a circ stent and then crushing the circ ostium and then extending the left main stent proximal to that intermediate lesion. So I think, again, you did all the hard work. I think from here on out, it's going to be pretty straightforward.
Yeah, right.
Any comment?
Anybody will consider
So,
further rotor blade lesion? I think 1.5 seems to be not enough because some regions still have more than 200 degree of calcification.
Yeah, right.
And after standing, it's still
So
overall in shape.
It's a very nice comment. So as a next step is we do at 2.5 several times compliant balloon, and next one, could you show? So, and we decide to the crush technique to completely revascularize and suck and LAD. Next one, after rotor ablation, what is the next step? Usually our choice.
What kind of the balloon for the LAD?
This is for LAD non-compliant balloon. After rotor ablation, there are several choices, and some position cutting balloon additional, some position scoring balloon additional, some position non-compliant balloon. Usually, my first choice is non-compliant balloon. This is a 3.0 non-compliant balloon. Next one.
As you see, there is still notching, not fully inflated.
Previous one. Could you show again? So after 3 times non-compliant, next one. And here is inflate, next one. This is 3.0, next one. 3.0, we try to inflate at 25 ATM, and next one. Okay, here, next one. Here, next one. We aggressively, meticulously inflate. Okay, next one. Here is the after implantation, the inflation of the non-compliant balloon. We can see there is some severe dissection of the middle part and proximal part, and we can find also severe calcification. At this moment, my strategy is very straightforward. I would like to do complete revascularization, middle and proximal LAD lemma, as well as distal sub to the proximal. Here is on the basis of IBUS, I put the 3.0 Giants 33 stent. Next one. Here is the next one. And then put the try to the distal sock, and looking at, as shown this case, and the acute angle, sometimes stent passage is very difficult. At this moment, I prefer the balloon anchoring technique, LAD part, stent balloon, and here, and we push the 2.75, 28 additional Giants stent, and the next one.
His technique is
Here
practically
is
very useful.
Yeah, right. And this is a 2.75, the 28. Next one. Here is we measure the overall the length, and because the IBUS does not pass, and the next one. And this is the next one. Okay, next one. Next one. Okay, here is the try to the crush and the balloon LED 3.5 non-compliant balloon, and the sock stand is 3.023. Next one. Okay, we try to stand booster used over here, and next one. Here, next one. Next one. 다시. Okay, next one. 다시 들어가서. Here is the spider view. We try to match small protrusion of the lamp main. Okay, next one. Here is the 3.023, and then inflation 2 and 3 times, and the next one. And then here is at the removing the sock profile, and definitely we require the 2 and 3 times high pressure balloon to facilitate the re-entry of the sock ostium. Okay, next one. And then remove the sock wire and the stand balloon. And then next one. Here is we try to push the high pressure balloon dilation using 3.5 or 15 non-compliant balloon. So So, and we remaining stage, put the main stenting crossover and then do recross the circle wire and then do final kissing balloon dilation. At this moment, I'd like to test it. Okay, Angel, ready? Okay. Push out. Okay. Very complex region, much simplified. Okay. I try to the
Complex
this is
lesion,
3.5,
but not
length
simplified.
is,
Complex procedure.
yeah, right. 33.
You make it simple, but not simpler. Just one comment about
Our paradigm is to make it simple. Okay.
Yeah. A comment about the crush technique. So you are doing a mini crush classical technique. Why not decay crush in this case?
Yeah. So and I definitely DK crush has a very nice good things, but the step is much sophisticated, complex for us, and as well as for DK crush we require at least 4, sometimes 5 non-compliant balloon. But our government just reimbursed up to 2 balloon. There are some regions. So our primary preference, if you're gonna do crush technique, and we do balloon crush technique. And sometimes do DK crush, but our primary choice is the balloon technique or the crush technique. Okay, test.
What size of the stent?
조금 더 빼.
This one?
This is 3.5.
Okay.
Yeah, a
You know,
giant.
I was finding the size of the vessel in the proximal area almost be 4O,
Okay,
and the left
잠깐만요.
main is
자,
almost be 5O. Angiographic appearance, it looks like a 3O. However, the real vessel size is much bigger.
12,
Yeah, at least 4.5 for the
14,
Lefevre.
16.
16.
The 3.5 is okay
Okay,
because
the
you
flip-
respect
this is-
the fractal law between LED, circ, and left main.
And the 4.0 and 3.5 stent are basically the
Okay,
same
this-
stent, but on
This
different
is
balloons.
3.5
So it's okay to
step.
post-dilate.
Okay, here, you're gonna check the angel. 자, 찍어보자.
So we have seen a good illustration
Okay, push out.
about the left hand control.
Okay,
so
good.
pulling back the balloon, you
Then-
control the
Spider view.
guiding catheter with the left hand to avoid longitudinal compression. I think it's very important.
Okay. Okay, good.
Good.
So much simplified. So, and the next step, I'd like to high pressure balloon dilation from the mid LAD and prox LAD and distal and main. And then I try to rewire to suck.
Okay.
And then finally do kissing balloon dilation.
Okay, good job. Continue your procedure. We will move to the another lab. Okay?
Epicranial. Okay, thank you. Thank you.
Thank you. It was very nice demonstration.
Dr. Colombo, can you hear us?
Good morning. Good morning to everybody.
Good morning, Antonio.
So this case is a 71-year-old. You want to present? Yeah.
Chest pain. His chronic factor was hypertension and diabetes. He received already PCI at left main to prox LAD and prox subcom using TAP techniques 7 months ago from outside hospital. And our coronary angiogram shows severe ISR at left main prox LAD. Next. And his risk factor is diabetes and hypertension, and his clinical presentation is stable angina. And next. And echocardiogram shows normal LV system function without regional motion, and TMT is equivocal. And next, our that right side coronary angiogram shows mild stenosis and mid RCA. And next. And 이거 지금 저희 거죠. Today our coronary angiogram. Today our coronary angiogram is showed the left main severe.
Can you? Okay.
Okay.
You see a proximal body of the left main, severe stenosis. There is some restenosis in the stent of the LAD, and the circumflex stent looks acceptable. Looks acceptable. So we have 8 French guiding catheter from the right femoral. We placed 2 wire B and W in the LAD and the circumflex. and we did the baseline IVUS on the LAD and on the circumflex. Can you show the IVUS?
Yes, IVUS was.
The first one will be from the LAD into the left main. So you see the stent, the distal part of the stent looks okay. It's moderately underexpanded, but not bad. It's a trio stent. We are moving toward the left main. Here it's a little bit hyperplasia between 3 and 6. It's a little bit more. Here is more. We are close to the bifurcation. Stent is a little bit bigger. And okay, here we are entering into the left main.
Okay.
You see some struts from the circumflex protruding at 6 o'clock. Here we are in the left main, which is a 4, maybe even bigger, 4.5. Soft tissue. And that's it.
Left main.
So here is very proximal, which is okay. So the plan is to predilate the left main with a 4 balloon short, place a short stent in the left main without going into the LAD, just the left main, 4. We don't really need to cover the ostium, maybe 12 will be enough, even 4.5. And then we will do a dilatation of the stent in the LAD, of the restenosis, with a trio cutting balloon. And then we will do drug-eluting balloon in the LAD. Maybe we may have some plaque shifting to the circumflex, so we are ready to do maybe a kissing balloon with another drug-eluting balloon in the circumflex.
So,
Any other comment or question about these cases?
so Antonio, can you tell us what was the initial technique which was done in this distal left main, or proximal LAD and proximal circ?
Yeah.
It looks like a V stenting, no?
Yes, it was a V stenting without much protrusion. There is a little bit of protrusion of the circumflex into the left main. So we are going with a 4 balloon. We keep the guiding catheter outside not to molest the left main. Let's do a test, please.
Dr. Bae?
Dr. Colombo,
Let's inflate.
according to the
Yes,
I was finding, I think that the main region is not covered,
10,
was not covered
15.
with stent in the previous procedures. Did you check the first angio in other
15,
hospital before the
20?
index procedures? I just wonder that it is the proliferative
But,
instant
yeah.
restenosis or
Down.
lesion progression in the uncovered area.
I think the left main was not stented.
Yeah.
The LAD, I think there may be some proliferation outside outside the lesion, stented, but it's really most of the restenosis is inside the stent. Let's take a picture.
In case
And,
for the
we
IS
decide-
lesion, the value of the imaging study was 2.
Yeah.
One is the evaluate the actual deployed size. In these cases, this
Let's
looks
take a
like a
picture.
3
Can
stent
I
in the
see?
proximal
I
LAD,
like
but
to
the
see my
selection is a
wire.
little bit smaller for therefore, is the under expansion should be considered. And the second one is the evaluation of what is the real characteristic of the neointima. Actually, this case is 7 months ago. So what is the type of the DS which was deployed in the LAD? And even though the IVUS evaluation is shows a little bit very looks like a soft neointimal characteristics in
Yes.
the 3 o'clock. it looks like some echolucent area, some
Can I have a
vulnerable.
cutting balloon for the LED?
So the two value. One is
Yeah,
the
three.
real characteristics of the neointima. Second was the real size of the stent. So when we look at this point, I'd like to recommend the OCT rather than the IBIS. And if you use the imaging caster, you say that the angiographically is the ostium of the circ is okay, but a little bit the hazy. So using in this case, why not evaluate the ostium of the circ as well?
We evaluated, we did IVUS on the circumflex, and we can show, can you show the IVUS on the circumflex, please?
So, Antonio, in this view, we
So
have...
there is a stent in the left main.
Yes,
we did
exactly.
not see, but there is a stent in the left main.
Yeah, we have seen,
Nobody told me
Antonio, in the RAO view after pre-dilatation, that there is a
Yeah.
stent in the left main, which looks very small. So the stent looks the same
Yeah.
size of, compared to the LED. And the stent in the LED was about 2.6, despite the fact that it was a 3.0. So I think it's really
Okay.
undersized.
Small test.
And it's probably the
Okay, let's
mechanism of
inflate. This is a
restenosis.
trio,
What size of the balloon
Is it
for
trio
the
cutting
LED
balloon?
dilation?
trio, we go to 20.
What about the
So
3.5?
the cutting balloon, but the trio cutting balloon at 20 is 3.5. Let's go to 22.
22.
Okay, down. So maybe we're not gonna stent the left main.
Yeah.
I think we will do drug-eluting balloon on everything.
So Antonio, if
Let's take a picture.
if the LED is 3.0 and the circ 3.0, the left main should be 4.0.
Yeah.
And we can see clearly that the stent is about 3.0.
You know, the pre-dilatation is not bad. There is some residual disease distally in the LAD, in the distal part of the stent. I think we're going to go there with a cutting balloon, not very high pressure, but we want to perfection that area. Let's get the cutting balloon again. Can you show the IVUS on the circumflex in the meantime? We did a
The size of the
baseline
caster is
IVUS.
8 French.
The size of
8
the
French.
catheter is 8 French. Let me clean the wire.
If you do the IVUS more after the cutting balloon at the distal to the distal margin of the stent and do the IVUS and the advance in the more distally for the actual size of the vessel. If the mid-LED size maybe 3.0 more 3.2, it
Yes.
maybe therefore we can think that the proximal LED size may be more bigger than the 3.0. So we have to change the more
Yeah,
bigger
the
size of
proximal LED, the proximal LED is 3.5. That's the reason why we use a trio cutting balloon. We inflated the trio cutting balloon at 22.
Oh, 22.
So it's much bigger than trio. You see, after we inflated the cutting balloon loses profile a lot. You see, it's not going. We need a new
You
one.
want?
Or we can use, we don't need a cutting balloon. We can use
NC
a non-compliant balloon, an
Trio or
NC balloon.
3.5?
Trio, because we are in the distal part
Trio
of the
NC.
stent.
10 maybe? 10 or 15?
10 is fine.
10.
10 or 15, doesn't
Or, okay,
really matter.
okay.
Whatever. So we need to dilate in the distal part of the stent of the LAD. We're going to go with the trio balloon. And can you show the IVUS on the circumflex? You never show the IVUS on the circumflex. If you look at the IVUS on the circumflex, you will notice that the circumflex stents protrude a little bit in the left main. And that may be the reason why now the cutting balloon has difficulties. Can you show the IVUS on the circumflex, please? Someone.
약간 스탠 나온 거 좀 보여줘. 프로트루전.
Oh, is this the IVUS on the circumflex?
Yes.
Okay. So you see the stent is a little bit smallish and protrudes a little bit in the left main. There is not much hyperplasia, but is underexpanded. Okay, you see this balloon went down okay. Test. Okay, inflate the balloon there.
노미날.
It would be very interesting to see the previous procedure to understand what was exactly done, because I have the feeling that the stent at the ostium of the circ was a little bit crushed by the stent in the left.
Yes. He's protruding because when I go with the balloon, I always have a little bit of resistance down.
So maybe it was a classical T-stenting, or I don't know.
Can I see?
Hi. This is
Okay. Ready for picture?
okay. So this is Tan from Singapore. I was just wondering, since the original
Okay.
technique was TAP,
The pre-dilatation results are not bad. So
previous
my
technique was TAP.
strategy
Now they
here,
already pre-dilated it. Will we consider doing a reverse crush? Just crush the thing, make it completely flat, and then recross and do a double kiss, rather than leaving that little bit sticking up from circ into the left main.
Right.
but
So
it's really,
with the TAP
I'm
technique
gonna
without
use,
the imaging
I'm gonna
guidance,
use,
the angiographic appearance is quite good. However, when you look at the image in this case, it looks like the stent was protruded beyond the ostium of the side
Yeah, and
branch.
it's quite small.
That is a reality.
So would it be a nidus to start your restenosis again next time?
30.
You know, the IBC
3.5,
evaluation is
30,
to clearly see
and,
that actually the length of the neocarina by the circumstance is not actually not short. It's a 2 bit. It's a clearly see. You see that. It may be have a role in the obstruct the advance some device from the main to the LAD.
I think this is a great example of why the TAP technique or the T-stenting is a suboptimal technique for bifurcations. Clearly, DK Crest shows that it's good results, but in my practice, I generally avoid the T-stenting or TAP. And if you have to reverse it, like you said, a reverse crush is probably the best way, because you saw when the cutting balloon wouldn't go. It's an example that just by a little bit of stent getting in the left main can preclude delivery of the device.
Yeah, so it's usually nice the first time around, but when you get restenosis, when you try to come and refix it, it becomes difficult. Even wiring, you may not actually get into the stent. You may be going outside the stent struct.
Okay, inflate there.
Great. 노미나 몇이에요? 7?
10.
10.
Okay. This is a 3.5 drug-eluting balloon for the LAD. Let's keep it for 1 minute.
1 minute.
We're at 10 atmosphere.
So Antonio, can you show the EKG of the patient?
The ECG?
Yeah.
ECG?
What you want to see, I didn't hear.
ECG 보여주세요.
Yeah, just to see it during long inflation. Yeah, thank you.
What size of the balloon?
Okay,
for
so we
the
are at 10 atmosphere, 3.5.
Actually the proximal margin of the balloon was the crossover the proximal
Yes,
margin of
yes.
the circ. It makes
And
some
we're going to
shift.
see a carina shift. Let's go negative. Negative. How long did we do?
1 minute.
1 minute, okay. So I'm sure that we're going to have a carina shift in the circumflex. So I think we need to do a little bit of inflation in the circumflex. Let's take a picture. Ah, it's not
Excellent.
so bad. What do you think?
Excellent.
It's not so. Do you think we should do balloon on the circumflex or not?
You know, it is questionable
I
toward the
think,
IVUS. It's a simple answer.
But the IVUS showed an intermediate result. I will do a dilatation on the circumflex. Can I have
Dr. Colombo, keep going on your
Another
procedure. We will
drug-eluting balloon,
move
yes.
to the another lab and back to your room.
Okay, you come back. You come back.
Okay, thank
You
you.
come back. Okay. Let's do a 3.0.
파이널 봐. 오케이. 오케이. So and we 오케이. 전에 그거부터 한번 키싱부터 한번 와이어 리와이링 하는 것부터 한번 보여줄까요? 좀 찾아서. 오케이. So and we use the rewiring. 오케이. 여기서부터 다 할 거. 리와이링 하는 것부터. Okay, here.
Dr. Bach, Dr. Bach,
Okay, next one.
Dr. Bach.
Yes.
Okay.
Okay, can you hear me?
Yes, of course.
Okay, we shows the next step. We use the Xion blue, the wire and the past well, the circle region. This is Xion blue, and next one. And then Prox LED anchoring using the 3.5, and we put the 2.5 compliant balloon, and then next one. And then this is a SOC 3.0 non-compliant balloon on the basis of IVUS. LED 3.5 non-compliant balloon on the basis of IVUS measurement. Okay, next one. We do high pressure dilation, distal part 3.0 non-compliant. Next one. Next one. Next one. Next one. Here is a previous one. Here is we inflate up to 20 ATM using 3.5 non-compliant balloon, sequential kissing balloon. Okay, and then here high pressure, and next one, Prox LED high pressure, the 3.5 up to 25 ATM. Next one, and then here, and we simultaneous kissing balloon dilation up to 10 ATM, 12 ATM, one time more. Next one. Okay, here is some pullback, the 3.5 LED, 3.0 the SOC, and next one. Okay, here is we're gonna check the angio again. Our final step is IVUS confirmation of the procedure success. Okay, angio ready. Okay, full shot.
Excellent.
Good. And spiral view. Okay.
You
Ready?
use the 4 stand. 2 for circ, 2 for
Yeah,
LED.
right. Yeah.
Total length
Yeah,
of
right.
it,
4 stand.
about the 4.
Might be, yeah. Overall length very long. Okay, and you
More
ready?
than 150
Yeah, right.
for the
So,
right
and
corner,
we
100.
measure the syntax score. Yeah, right. It's more than 200, something like that. So and we try to keep the depth at least 1 and 2 years, something like that. So, and overall, our initial mission is try to reduce the syntax score less than 5. We measure syntax score 6. Yeah, our mission was
Excellent.
failed. Yeah, so I think that this is our stereotype. How do you treat the very complex main lesion? Is a very educative case. How can you do rotablation? How can you do decision making? How can you do crush technique? And this is a very educative case.
Right. Excellent
To,
skill and
final
very educational.
part.
Yeah, okay, Dr. Ng, okay.
Okay,
Okay,
any
comment.
comment? We will move to another lab.
Okay.
Thank you. 우리 LAD만.
Okay, Dr. Kang. Dr. Kang.
Yes, Dr. Hong.
Okay.
Yes, I can hear you. Yeah.
Okay, please introduce your team and your cases.
Yes. Good morning, audience. I'm Dr. Do-Yoon Kang, and this is my team, Dr. Hyun. He will introduce our patient.
Okay, 75 years old male admitted for aggravated aortic angina. He had hypertension and diabetes. He received thrombolysis and also received PCI with bare metal stent at left main and diagonal branch, and RCA with bare metal stent and first generation DES. His coronary angiogram showed diffuse severe ISR at RCA and diffuse severe stenosis at LAD. Subsequently, he received PCI at LAD 2 days ago. He had diabetes and hypertension. His clinical presentation was unstable angina. Echocardiography showed normal LV systolic function with RCA territory regional wall motion abnormality. He received LAD PCI 2 days ago.
다음, 엔지오 보여주세요. Yes, the patient, 75-year-old gentleman who received RCA BMS stenting 20 years ago, and 11 years ago again with Taxus for BMS ISR. And after 11 years, once again the ISR occurred. Yeah. So the angiography shows diffuse instant restenosis in the full segment of the stent. Next. So I had wired into the RCA and tried to see the OCT, because the OCT shows the more detailed image of the instant restenosis and its mechanism. I decided to evaluate it by OCT, but it could not pass the region. Next. So I inserted 2.5 NC and applied about up to 28 ATM. Next. Next. And next. And I could next evaluate the OCT. Yeah. Next. Can you please show the OCT image? Yeah, this is the baseline OCT. They showed diffuse instant restenosis with the instant calcification, which means the neoatherosclerosis. And you can see the 2 layers of the stent, and in very short segment, there is 3 layers of the stent with the BMS outside and 2 overlapped taxus inside. And you can see the neoatherosclerosis with the calcification with diffuse ISR. Yeah. Next. So I treated, I decided to treat with the 3.5 scoring balloon because the stent size was 3.5, but it did not pass the angle of the RCA. Next. And I used the GuideZilla, the daughter catheter, to introduce the bigger balloon and apply 3.5 scoring balloon up to 20 or 24 ATM. Next. Next, there was still indentation, but became much better with higher pressure. Next. 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 And now I'm here. I checked the OCT. Can you please show the OCT image? After 3.5 scoring balloon up to 22 ATM, 22, 24 ATM, the lumen became much bigger, and I can find some instant dissection with preserved lumen area. Yeah. Yes, I want to ask the panelists that how you just treat this patient more or not.
I think it's a very interesting case, a very old stent with neo-atherosclerosis.
Yes.
So it's very important to check the mechanism of restenosis. And in this case, because it's neo-atherosclerosis, I will use a drug-eluting stent, not a drug-eluting balloon. One of the problems in this case is support that you need. Is it 7 French or 8 French, the GR?
This is 7 French.
7 French.
Yeah, 7 French, okay.
So to put a long stent in this vessel will not be so easy. Maybe a better support can be obtained with 3D right, for example, or implants. But you have the help of extension catheter to deliver the stent.
For me, actually, I thought that the patient already have the 2 layers and somewhere 3 layers of the stent, and he's 75-year-old. I wanted to avoid the additional layer of the metallic stent. How about the DCB for this case?
You know, if we look at the literature for PAD and SFA disease, what we know is that when you apply a balloon to intimal hyperplasia, basically you extrude a fluid, but eventually those cells rehydrate and cause restenosis again. If laser atherectomy is available, perhaps some degree of debulking may be an option. There is still intimal hyperplasia inside the stent, so it's a consideration.
Any other comments?
Yeah. I want yeah.
So, Dr. Yun, this is Dr. Yun. So I also agree with Dr. Lefevre for this ISR, long diffuse lesion. I also wanted to put a drug-eluting stent. As you see in the OCT image, there was such kinds of little dissection, and that means in the long run, it might cause fluid hemodynamics, so might enhance the ISR again. So I just wanna put the DS for this reason. That's my personal opinion.
This is Tan from Singapore. Okay, so in not a too distant past, we used to have BVS. So that was one of the options. You wanted a stent, but you don't want too many layers. You put a plastic stent. Currently, of course, BVS is no longer available. However, there's still McMaris. So that's a magnesium stent. So you can still have the support of a stent. You can still squeeze things out, and hopefully it will dissolve. Would anybody consider that?
Unfortunately, the McMaris and yes.
Yeah, actually, I think that there is technically it's not so difficult cases, but the decision is not so simple because you already mentioned that patient had already 2 layers of stent, and so if you put one more, I don't think 75 years old and then the longevity of dual antiplatelet therapy is not unlimited maybe. And so, yeah, I already see that, the OCT, there is some minor dissection or something, but the flow is good, there is no flow limitation. And so I think the one time of DEB can be one alternative to that kind of specific patient.
Dr. In?
Yes.
So if the patient already have 2 layers of BMS, so, to our experience, this is a diffuse proliferative type in-stent restenosis. And if you just do DCB, it might not be good in the long run. So I will use Synstra DS for this procedure and to see what happens later.
Actually, this case is a really tough case. The reason why the reason was the 2 stent was a stent sandwich. So the achievement of the larger size of the lumen area is some difficulty. When you look at the angiogram in the proximal RCA, the size of the vessel is quite larger compared to the beyond the proximal one. So the actual vessel size in this patient is looks like more than the 4.0, but there is already
yes, it was more than 4.0.
Yes.
Yeah.
So even though we dilate the angiographically, there is some flow, but it is a very difficult. And even though you did the scoring balloon, and when I look at the scoring balloon, it is not fully inflated. There is some indentation. So it's a really tough case. Okay.
I'm Dr. Chung from National Medical Center, and I have a question to Dr. Kang and the panelists. This case is the Texas, the Restenosis case. So if you use the paclitaxel drug, eliciting blood, then the same antiproliferative drug is used. So there is a risk of the Restenosis. So I think it's a question to the four layer in some parts, but I think that the different antiproliferative drug should be used, I think, yeah.
And I will do a more aggressive cutting balloon and the non-compliant balloon angioplasty before stenting.
Okay, 우리서 4.0 발론 줬어요.
Good question.
Yeah.
Is the sirolimus eluting balloon available here?
No, sirolimus eluting balloon is not available here.
Okay, there is no clear the answer. Anyhow, keep going your procedure.
Yes.
Dr.
I will
Kang?
apply more high pressure because yes.
Okay.
Here.
Hello?
Yes,
Okay,
we hear you.
We have finished. I'll show you what we did. So this was a cutting balloon, a trio at 22 atmosphere. Next. Then we use a non-compliant balloon, 15 atmosphere, a little bit more distal. Next. Then we did a 3.5 drug-eluting balloon, proximal LAD, a little bit in the left main. Next. Then we did a trio, a long drug-eluting balloon in the circumflex. Next. Then we did the kissing to reshape the carina. Next. Then we did the hugging balloon for the left main because they don't have a 4O. We use a 3O and a 3.5 drug-eluting balloon. Next. We went with both also in the LAD and the circumflex for 1 minute. Patient tolerated well. And this is our final picture. Next. So I think
Excellent,
we are pretty
Lee-jung.
happy. So we didn't place any additional stent. We did a hugging balloon in the left main, and I think it's okay.
Could you show us the IVUS image from the LAD to the left main?
We can do some IVUS, but I don't think we have to do anything more. Because it's really, the lumen is fine. We inflated both balloons at 15 atmosphere, so it's over 4.2, 4.3 if you put them together. Look, really nice.
Right, we agree. But we want to see that what is the IVUS image.
Yeah, we can do the IVUS, but maybe we'll show you at the end. Okay. If you don't have any more questions, we do the IVUS, and then we tell you what we found. Maybe on the circumflex, which is
Beautiful
the most
appearance.
interesting.
Agree.
Okay. Okay, can we go in the caudal areole? Okay, I don't know if you want to stay for the IVUS or not. It's up to you. We're going to do quickly. I was from the circ into the left main and see if we crushed the protruding or is still. I bet the stent is still there because we did not crush, but it depends.
Yeah, I think, Antonio, it would be nice to see the IVUS because we'll understand more what was the technique which was done before, and we'll see probably
I think was most probably like a T or a
tap,
V,
yeah.
with another stent, something like that.
Yeah.
Okay, we are going into the circumflex. Okay, let's start from there. Okay, so IVUS from the circling to the left main. Okay, start pull back. Okay. So we are distal to the stent. You're going to see the stent in the circumflex in a moment. Here it is. Looks not bad. Maybe it's a little bit more expanded.
Yeah, but it's better expanded, clearly.
With the drug-eluting balloon, we did it. Okay, here we are moving towards the left main. No, it looks better, much better.
Yeah.
Huh? More round. I think here we are in the left main. It's not crushed. It's protruding. It's not crushed. This is the left main. That the one that you see is a wire in the LAD. The left main looks clean. Huh?
Yeah, clearly the stent was not
I think it's good.
well expanded in the left main before, so now we have very
Yeah.
nice
I think
expansion.
it's okay. What do you think?
Excellent.
I think we can close the case. Okay, so this is a classic drug-eluting balloon for in-stent restenosis. No additional stent. We did a little bit some stent expansion as well. So I hope this gentleman will do well. If there is another recurrence in our hospital, we will do bypass surgery. I think it's enough. Okay.
Okay, excellent
Thank
job.
you very much.
We will move to the another lab.
Yes,
Dr.
good morning, Dr. Huang. Yes.
Okay.
Dr. Kim, could you introduce patient history?
I'm Dr. Kim. This patient is a 66 years old male with recent myocardial infarct, was referred from other hospital for management. He underwent the PCI at ICA in other hospital 1 month ago, but there was a residual stenosis left coronary artery system. So next. His coronary artery disease risk factor is diabetes, hypertension, hyperlipidemia, and smoking, and family history of coronary artery disease. His clinical presentation is stable angina. Next. His cardiac function is preserved, but the other functional study was not done. Yes, his previous stent at the ICA is patent, but the left coronary artery disease in the left coronary artery disease system, there is a remain bifurcation disease.
Okay, continue. Keep going. So we did not the whole story. Please explain more.
Yes, patient complaint chest pain, so
Okay.
finish some procedure and I will explain.
Patient safety first.
Okay. Ready?
Ready.
Okay. So could you show us the initial angiogram? Actually, patient have RCA stenting in the other hospital and transferred to our hospital for the treatment of left side coronary artery disease. So his age is 66-year-old. Firstly, we recommend the bypass surgery. He refused the bypass surgery, so we prepared the patient for left main stenting. So this is epicranial view. The proximal LAD is involved a very calcified long disease involving the first and second diagonal branch. Diagonal branch is not so big. The next, previous caudal view, please. Caudal view, please. In addition, left main bifurcation involvement. Left main is big, but the circumflex ostium looks tight. I think definitely this is a kind of indication of bypass surgery, but now we are preparing for the left main PCI and LAD PCI. So
And geographic
what is your
appearance
idea?
looks like
Can you
the
comment?
first cases of the today.
Highly
Yeah,
calcified.
exactly, similar cases.
Okay, keep going.
Next. So the proximal LAD looks very tight and very calcified lesion. So we decided to do rotabulation first. Next, please. Next. Next, please. Insert to the microcatheter and change to the rotar wire. And next, please. Next, please. We perform the rotabulation with the 1 to 5 bore. So I felt a very big resistance in this patient. The combination of a very heavily calcified lesion and tortuous region. So be careful to do the rotabulation. Sometimes rotabulation stop this, or sometimes make the preparation. So don't push a lot. The stay more time is sometimes very important. Next, please. After rotabulation, next, please. I changed the wire to the conventional BMW wire. Next, this is 2.5 high pressure balloon. Next, high pressure balloon is well expanded, no indentation. We have to check if there is some indentation. We have to do rotabulation again. If there is some balloon indentation, never implant a stent. Next, please. So after the high pressure balloon 2.5, we evaluated the IVUS. IVUS show that the LAD is 2.75 and proximal LAD is 4.0, left main is 4.0. Compared with the baseline angio, so can you see the baseline angio?
Now we see the IVUS image. Okay.
Okay, this is LAD. This shows the proximal LAD. This is a proximal LAD, very calcified. We just passed the calcified LAD lesion. And vessel size is very big, 4.0 vessel, proximal LAD. Compared with the angiogram, so huge difference. The angiographically only at most 3.0, but the IVUS show that the 4.0 vessel.
Right.
Involving the LAD ostium. And can you show us the circumflex? Can you show us the circumflex? Circumflex pullback, please. This is circumflex pullback. Circumflex is big as well. Vessel size is 4.0. Here is a very tight lesion, flux circumflex. Here is the ostium of circumflex. So we decide to do the bifurcation stenting for left main bifurcation. So next, please. So we implanted the 4.0 circumflex stenting, and the LAD balloon is 4.0 high pressure balloon based on the IVUS finding. Next, please. Several times high pressure ballooning before circumflex system remover, and previous, please. And this is a balloon crossing for circumflex stent. Next, please. And then this is LAD. With LAD vessel size at 2.75, so I implanted 2.75. The delivery is not easy, so I insert the guide jewel like this, and then next, this is 2.75, 38 millimeter, considering the distal edge dissection or risk of some vessel dissection. So I selected a smaller size stent. Next, please. Next, please. Proximal stent is 4.0 based on the IVUS finding. Next, please. I implanted the 4.0 balloon, 4.0 23 millimeter stent. This is my procedure so far. Ready? Fortunately, LAD diagonal branch looks fine. And left main bifurcation looks good. So after main branch IVUS, because I believe that the main vessel optimization is more important than side branch treatment. So the before side branch rewire or balloon crossing, usually I like to do the LAD IVUS evaluation for LAD stent optimization.
So, Dr. Han, you have done a T-stenting, systematic T-stenting approach in this case. Do you plan to open the strut toward the circ or not? Is it a crush?
This is initially yeah, this is crush technique, balloon crush technique.
It's a micro crush.
I don't know. I cannot do the micro.
but do you plan to do a kiss before, at the end of the procedure?
Yes. After main branch optimization, I like to do the final kissing. Please give me the 3O high pressure balloon. Yes.
Dr. Han, that was a really tremendous atherectomy you did. It was a very complex atherectomy. The tortuosity makes it very difficult, very risky and dangerous. You selected a 125, which was very appropriate because you don't want to oversize, especially if there's proximal vessel tortuosity. So I think that was a very excellent choice.
I think my purpose of the atherectomy is just to make a break, not make a big lumen, but just to make a break. Making the big lumen, we can do it by the high pressure balloon. So after rotabulation, I apply the 2.5 high pressure balloon for make the lumen.
Agree. It's a concept of some plaque modification rather than the debarking.
Yeah.
10.
What size of the balloon?
12, 14. 3O. High pressure balloon.
You deploy the left main to the proximal LAD is a 4O, and the left main LAD is a 3O. There is some size gap. So after the balloon dilation, I'd like to recommend the IVUS once again, and what is the real size of the proximal LAD?
20. Yes. 20, 24. Deflation. Okay. All high pressure balloon, please.
I think this case would be an example of even if he had the shockwave lithotripsy device, I don't think it would have crossed the lesion. I think it still would not obviate the need for atherectomy. In general, if you get a wire down, rotational atherectomy can go down. What I use as my barometer to see if a shockwave lithotripsy will go down is if a 2O balloon can't go down, in general, that would tell me that the lithotripsy balloon won't go down. So I don't bother opening up the balloon. It's a very expensive device, roughly about $3,000 US. So you could open up a 2O monorail balloon. If it doesn't cross, don't open the lithotripsy balloon.
Have you tried what is known as rotatripsy? Because the rotablator will never run out of usage. As you said, because when you have a very tight lesion, there's no way a shockwave can go down. But you use a 2.5 burr and followed by the shockwave balloon.
A 2.5 burr?
A 2.5 burr, so that you can bring your shockwave balloon down. So you don't actually upsize the rotor. And sometimes you get a lot of calcium, very thick calcium, right? So you need to go from 2.5, 1.5 burr. So instead of using another burr, you use
Give me 1.25 burr.
Yeah, sorry.
I'm sorry. When you said 2.5,
sorry,
you don't have a 2.5.
Yeah, right.
I'm very reasonable, right? So the smaller the burr, less chance of dissection or perforation, creates a channel. Then you can do more definitive lesion preparation.
So a hybrid rotatripsy.
Deflation.
Cost at that point would be very high.
That's right.
그래. Dr. Han, continue your procedure. We will move the Dr. Kang. Okay?
Yes.
Okay.
Thank you.
Dr. Kang? Okay.
Yes, Dr. Huang. I applied 4.0 NC for the more high pressure inflation up to 24 ATM.
Please show us the angiographic appearance, not your face.
Yes. Next. And the angiographic appearance is good, and the OCT finding shows only minimal dissection, and minimal lumen area was 4.5. So I wanted to avoid additional metallic stent for the 2 or 3 layered patient, 75-year-old. And second, if I implant one more drug stent, the lesion will be really undilatable when it recurs. So I applied drug-eluting balloon again, and if the patient recurs, and I will try some debulking devices and consider additional metallic stent. Next. And so I applied 3.5 drug-eluting balloon for 1 minute, and distally and proximally. Next. 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 Yes. And this is a final. Next.
Considering
final
that the
OCT.
patient age, so your decision is quite reasonable and practical.
Dr. Kang, any reason why you used a guide catheter with side holes?
Yes. Because at first I thought about that there is some opportunity to implant one more stent up to the diagonal ostium. So I used the side hole, guide catheter with a side hole. And I used the guidula, and with the guidula, the side hole is obstructed, so I can save the contrast during the OCT.
Okay, excellent
So
job.
usually if there is no ostial lesion, I use the guiding catheter with a side hole.
Any question? More questions?
I think it's the best that you can do with balloon. But again, I think the risk of restenosis is not low, despite an optimal result that you have done with this technique. So because it's a very old stent, I will not be afraid to add a third layer of drug-eluting stent. But okay, let's try and see the outcome of the patient.
Yes, okay, thank you.
Would anybody consider using a covered stent for this patient? For 3 layers of, if it fails 3 times?
But the risk of restenosis with this kind of stent is very, very high, and the risk of stent thrombosis is also very high.
I think it's a DB or a DS might be a good option for this case, because maybe we can apply the DB, and maybe he got a quite good result. I think that would be good, but considering the wrong lesion, long severe diffuse restenosis, so maybe a DES might be another option for that, for these cases.
Can you see the IVUS imaging? Yeah. Yes. Okay. This is the distal landing of LED stent. Stent is already expanded. I didn't apply the high pressure balloon here. So based on the IVUS imaging, I can apply the 3O high pressure balloon from here. Okay, Stenting is so far so good. But definitely we need a high pressure balloon for here. And from here, vessel size is about to increase. Here, vessel size almost 4O. Very small lumen. And here is a prox LED. Left main. You can see the crushed circumflex from the 1 o'clock. Left main state is well opposed. So before circumflex wiring, I'd like to apply the high pressure using the 3O balloon. Please give me the 3O high pressure balloon.
So what do you mean with high pressure? Is it OPN-NC or just a non-compliant balloon?
This is just a non-compliant balloon. We don't have the OPM balloon, so unfortunately.
Okay.
So using the balloon not easy to passing through so guide chiller sometimes is very useful to deliver the device.
Dr. Han, did you fix the circ? Not yet.
10.
Yes, already implanted, not yet.
Oh,
20,
okay.
24.
24.
Deflation.
Okay, Dr. Han, keep going your procedure. We will have the lecture. The DW Bach, he's waiting for his presentation.
Okay. See you again.
Okay, thank you. So I'd like a 10-minute lecture about the left main PCI. Today my topic is focused on the practical issue as well as updated evidence. This is my disclosure. So, and my topic is focused first the practical issue, how can you treat left main PCI? Second part is I'm gonna briefly review updated evidence for left main PCI. So looking at how can you treat the distal left main bifurcation treatment, and there are many bifurcation clubs, and the EBC, and the Asian Bifurcation Club, and the Korean Bifurcation Club, etc., etc. And usually they have a mainly focus on technical concept, part, repart, KO, TK crush, gullet, and details, and more details. So, and the too much complex angiographic concept, angle, curve, diameter, and longitudinal, and relevance of side branch is caused the left main bifurcation PCI looks like a statistical PCI. So, and looking at the clinical relevance of the side branch suck when you do left main bifurcation PCI on the basis of functional CT-FFR data, looking at the left main LAD and suck, and the suck ostium usually supply the functional myocardial burden more than 10%. The reason why we should be much cautious about the treatment of suck ostium. How do we treat? It's simple. 1 stent crossover and 2 stent. So this is our long-standing theory, and the suck ostium, normal or diminutive suck, just a focal disease suck, and we prefer definitely 1 stent. Diffuse suck and the large suck and the dominant suck, and we prefer upfront 2 stent technique. So, and looking at the distal left main bifurcation region, and there are diversity of side branch narrowing, and as shown here, and the different type and different anatomy, and one is a focal moderate region inside the branch, another one is a focal severe region inside the branch, another one is a diffuse region inside the branch. So simplify, and usually focal moderate, focal severe region, our team is prefer initial provisional strategy, initially diffuse region, and big suck, very tight complex region, we prefer upfront 2 stent strategy. So, and why we do upfront 2 stent strategy is a large suck, and the relevant suck is a worst of treatment, and the clinical outcome 2 stent with the contemporary drug lowering stent, as well as updated technique, is very nice. Also, we can avoid the risk of side branch closure during the left main PCI. That means stabilizing treatment side branch first has advantage. So, and looking at the DK Crush 5 trial, its a key message is the right side, initially complex suck ostium, very tight, very diffuse region, is a treatment effects much profound in complex region. 2 stent is good. Don't do 1 stent for true severe the suck region. But looking at the Excel study, they divided the provisional 1 stent versus planned 2 stent. For true bifurcation region, central 2 line is one is 1 stent, one is a 2 stent. Looking at the hazard ratio was no different. It's almost off line and almost low line is that is initially non-true bifurcation region. looking at the data and for non-true bifurcation lesion, if you're gonna do planned two-stent technique, the outcome was bad. So, and the Excel sub-study message, don't do two-stent for non-true bifurcation region. So FFR concept is also important for when you do left main stenting. And after stenting crossover, looks like angiographic pinching. And if you consider FFR, FFR is okay, just leave it alone. Long-term outcome is good. Also, as demonstrated yesterday lecture, IVUS determined the strategy. As shown is our first live case. On the basis of IVUS, we can decide stent or not, also stent sizing and the stent length. So, and the IVUS criteria is 5, 6, 7, 8. If you achieve the sufficient effective cross-section area, that guarantee very nice long-term outcome. Practical guideline, how to do left main PCI. IVUS evaluation, both branch is strongly recommended. No disease suck and the small suck, definitely we prefer single stenting. More than 75% we can do single stenting. After stenting crossover, suck ostium looks like a jail. How can I do? Next step, we consider FFR. FFR is okay, just leave it alone. FFR was compromised. We do just a final kissing balloon, sometimes do optimal T-stenting. Initially, true bifurcation region, the shown as DK-5 trial, complex region type, we initially do upfront two-stent technique. So how to optimize? Whatever you choose, the different type of stent technology, and the IVUS cross-section area is important. IVUS tuning is very, very important when you do complex left main PCI. So second part of my talk is the updated evidence for left main PCI in contemporary PCI setting, and looking at the history of revascularization RCT and the continuous being matched over the last 30 years, and recently Noble trial and Excel trial. So, and over time, the treatment gap PCI and the KBG in left main is diminished. Its mortality gap is currently second generation drug-eluting stent. Mortality gap nearly narrowed, shows the similar mortality and hard endpoint. And this year and next year, PCI and bypass surgery in left main disease and intermediate anatomic complexity, PCI bypass surgery was comparable. Stroke is higher with the bypass surgery. Repeat revascularization was higher in PCI. But game is just begun. We remaining one important thing is a very long-term outcome required to guarantee a long-term patency of treatment effect. And looking at the recent study, Excel and Noble study, there was some signal. You know, over time, there is some phenomenon, late catch-up, crossover, favoring bypass surgery over PCI. So, and I'm going to briefly review and recent updated data. This is a Lancet published individual patient data meta-analysis. 11 random trial includes bare metal stent era, drug-eluting stent era. It's a left main multi-vessel. Left main, there is no difference at all in all-cause mortality, but multi-vessel bypass surgery is good for left main, the all-cause mortality. It's what are new in the last TCT late-breaking trial and something like that. And this is a 10-year outcome. It's a registry, our initial registry published in New England Journal of Medicine, looking at 10-year full report main compare outcome after adjustment beyond the 5-year drug-eluting stent, statistically higher mortality, as well as in terms of death, QMI, stroke, bypass surgery was better than drug-eluting stent. But our main compare registry is suffer from some inherent limitation owing to unmeasured compounder. So this is the Syntax 10-year study and presented the ESC meeting, looking at full-term all-cause mortality. 3-vessel disease is all-cause mortality was better with bypass surgery, but looking at left main coronary artery disease, there is absolutely no difference. So, and last TCT meeting, there is a very debatable presentation was done by Dr. Gregson, 5-year Excel trial. Looking at the primary endpoint overall, there was no difference, but primary endpoint, there was a curve change. Initial time, bypass surgery is poor,
PCI better. Over time, the PCI was poor, bypass surgery is better, and the odds ratio is not statistically significant. But looking at, as shown, is the first time PCI is good due to peri-procedural MI, and over time, the bypass surgery is good. However, one of the debatable portion, looking at all-cause mortality, is PCI at 5 years, 13.0%, bypass surgery, 9.9%, is statistically higher. Its primary endpoint is no difference, but all-cause mortality is the most strongest hard endpoint was different. So, after release of XL5 trial, there are a lot of debate, endless debate. You know, cardiac surgeon, our longtime friend David Taggart said at the meeting of late, he accused the XL investigator of stacking the deck in PCI favor. It's, you know, very hardest debate. Our team is embarrassed. Greg Stone is our longtime friend, as well as David Taggart is our longtime friend. It's difficult to decide our stance at this moment. So, in the pre-combat trial in 2011, we presented a 2-year outcome, New England Journal of Medicine. Final full 10-year report will be presented next year, ACC late-breaking trial by S.J. Park. So my final message, meta-analysis available data shows the mortality and serious composite outcome was similar drug-eluting stent bypass surgery. Main compare, bypass surgery is better, but this is suffer from inherent limitation. Syntaxis shows the similar 10-year all-cause mortality between PCI with the Texas and bypass surgery. All-cause Excel shows the similar 5-year rate primary composite endpoint, but higher all-cause mortality after PCI than after bypass surgery. Some conflicting finding definitely should be confirmed or refuted through extended follow-up landmark clinical trial, including our pre-combat, our BEST, and EXCEL, and NOBLE trial. Thank you for your attention.